First of all, I would like to thank you, Professor Cecchi and Jacopo, for this invitation. And I would like to start to introduce this topic with a clinical case. This is the echo of a 37-year-old lady who came to our attention due to palpitations. As we can see, the echo showed left ventricular enlargement and diffuse global hypokinesia. Of note, posterior wall thickness was 12 millimeters and muscle were a little bit hypertrophied. Peculiarly, posterior basal septum was thin and akinetic. Even if an optimized medical therapy was started, the lady underwent heart transplantation in 7 years. And here we have her heart, and we can really appreciate the huge amount of fibrosis that involve the most of myocardium. Histology also confirmed the huge amount of fibrosis and also showed hypertrophy and disarray. By familial screening, we evaluated her 15-year-old daughter, and here we have her ECG and echo. The ECG with half voltages showed an impressive left ventricular hypertrophy with negative T waves in the infralateral leads, whereas the echo showed a classic hypertrophic cardiomyopathy. However, the same familiar peculiar sign of thin septum localized at the basal level was present. In 5 years, both ECG and echo changed deeply. In fact, we can now appreciate a decrease in QRS voltages and enlargement and ST elevation with isodiphasic T waves and pseudonecrosis in the infralateral leads. Also, the echo changed a lot, and we can see now an enlargement of the ventricle with marked diffuse hypokinesia, mitral tricuspid regurgitation, moderate to severe. And also the MRI that we performed confirmed this enlargement and diffuse hypokinesia. Gadolinium infusion showed an important late enhancement that mostly involved the septum, but we can see that also the entire myocardium was involved from all these views. In fact, the most of the myocardium is gray. And even in this case, heart transplantation was necessary. And in this slide, we have a comparison between the explanted heart and the MRI image with gadolinium infusion. And we can see the huge amount of fibrosis, blue colored, that is mostly intramural, but in some parts subepicardial, and in other even transmural. We perform a genetic analysis evaluating 10 genes, 8 sarcomeric genes and 2 metabolic. And we found 2 new mutations in LAMP2 and myosin light chain in the mother. However, these 2 mutations were not found in the daughter, even when the test was repeated both on blood samples or myocardium. So I wanted to show you this case since I believe it includes some important key points. In fact, I believe we all agree that this disease was clearly familiar, that involved young age, had short time course. Ischemia is a possible substrate. However, the genetic substrate is not clear at all. Now, when we speak about end-stage hypertrophic cardiomyopathy, we speak about left ventricular remodeling that brings the classic HCM towards a condition characterized by enlargement, wall thinning, and hypokinesia. However, we have to keep in mind that in the large spectrum of remodeling, we also can find a reduction in ejection fraction in the context of a normal or mildly dilated ventricle that still presents hypertrophy, usually associated with an enlargement of the atrium and increase in left ventricular filling pressure. Now, the major case series reported a prevalence of end-stage disease that ranges between 2.5 and 5%, and a prevalence that ranges between 0.5 and 1.1 per 100 patients here. The same reports also found some common clinical and instrumental findings that distinguish these patients compared to patients with classic HCM. And these are young age at diagnosis and first evaluation, an important family history for end stage, larger LV cavity, and greater wall thickness. And for what concerns family history for end-stage, the major series reported the prevalence about 30%. And this is an example of a pedigree of a family from Bologna, where we can see that two brothers had end-stage HCM. One was transplanted and the other died for heart failure. In the same family, we also had a family history for sudden death in young age, whereas other patients had mild phenotype, apical or not obstructive. But what are the pathophysiological mechanisms of end-stage HCM? The focus is on myocardial fibrosis, reversible ischemia, and genetic substrate. We know, in fact, as the previous speaker also told us this morning, that the most of these patients are characterized by large amount of fibrosis into the myocardium, and these are 3 different explanted hearts of our patients. And we also know that there is an important remodeling of coronary arteries characterized by huge hypertrophy of the media and the virtual lumen. And these anatomical findings could have a clinical or instrumental correspondence. In fact, Professor Camici and the group of FLORENCE taught us nicely in this paper as microvascular dysfunction is an important marker for a progression towards end-stage HCM, and also how it correlates with a very bad prognosis. The same group of FLORENCE also showed us that there is an important inverse relation between the amount of gadolinium and ejection fraction. And this is especially true in patients with classic HCM, but it's true in patients with classic HCM, but especially in patients with end-stage evolution. However, any theory needs to explain some findings, such as the fact that this disease is time-dependent but not age-related, that reversible ischemia, severe hypertrophy, and young age seem to be predictive factors, that large myocardial fibrosis is a common histologic feature, and that there is an important familial aggregation that could raise the suspicion of a different genetic background in this population. These, together with the fact that the recent reports tell us as patients with double or multiple mutation can have a higher risk of sudden death, and in this paper with, who reported about patients with triple mutations, also a higher risk of heart failure and development of end stage, is an important point. So on the basis of these preliminary remarks, we decided to perform a multicentric study that involved 156 patients with end-stage HCM. We evaluated 10 genes, 8 sarcomeric genes and 2 metabolic, PARKAG and LAMP2. And 8 centers participate to this study, 6 from Italy, Bologna, Firenze, Napoli, Genova, Roma, and Bergamo, and 2 from USA, Boston and Minneapolis. And we tried to answer to the following questions. First, are genes and mutation different or similar between patients with end stage and patients with classic HCM? Second, from a quantitative point of view, the genetic burden, the number of mutations is different. And third, if there is any relations between geno and phenotype in the end stage cohort. These are the clinical characteristics of the patient's population. 55% were males. That may be a little lower prevalence compared to case series with classic HCM. Median age at the HCM diagnosis was 30 years, at first evaluation 44, at end stage diagnosis 45. 60% of the patients had a family history of end stage, and of note, a third of the patients had a family history of end stage. At end stage diagnosis, the echo showed a median maximum wall thickness of 17 millimeters, left ventricle of 53 millimeters, and an ejection fraction of 45%. We found 130 mutations in 104 patients, almost 70%. That means that even looking for 10 genes, a third of a patient had a negative genotype. Between patients with positive genotype, 35% had new mutation, so not previously described. The most of these mutations were missense and followed by some framesheet nonsense or involving the splice site, but almost 80% were missense. For what concerns the genetic burden, around 50% of the patients had single mutation, whereas 13 patients had multiple mutations, 10 double and 3% triple. And myosin-binding protein C and myosin-heavy chain were the two most involved genes, followed by troponin 9 with 9%, whereas the other gene had a distribution rates that ranged between 1 and 4%. We just had one patient who had a mutation in LAMP2, and this patient also had a mutation in troponin T. Then we compared this patient with 181 patients with classic HCM, and we did not find any differences in terms of both gene and mutation involved. And this is just an example of myosin-heavy chain gene. The only difference that we found was in terms of multiple mutations. In fact, we found 13% of multiple mutation in the end-stage patients compared to 5% in patients with classic HCM. For what concerns correlation between genotype and phenotype, patients with positive genotype were younger at HCM diagnosis, first evaluation, had a higher family history for HCM and a smaller left ventricle. However, they were more frequently relatives of the proband. Then we divided the patient according to the structure of the mutated protein, so that we divided patient with mutation in thin filaments, thick myosin-binding protein C, or multiple mutation. And we found that patients with myosin-binding protein C mutation were older at HCM diagnosis, first evaluation, and even if not significant, end-stage diagnosis. And this slide summarizes clearly these concepts so that we can see that patients with myosin-binding protein C had a later onset in terms of both HCM diagnosis at the end stage. Differently, patients with thin filaments had a higher ejection fraction compared to the rest of the patients. Importantly, patients who experienced end-stage HCM before 20 years had a much higher prevalence of multiple mutation, around 40%, compared to patients that developed such condition later on and that had a prevalence of around 20% of multiple mutation. Now, for what concerns the outcome, after a median follow-up of 3.6 years, around 50% of the patients reached the endpoint HCM-related death, including heart transplantation and appropriate ICD discharge. Around 80% reached the endpoint heart failure, heart transplantation, and 10% sudden death. We compare positive genotype with negative genotype, single, multiple mutation, or according to the mutated protein. However, we did not find any correlation in terms of events. And this is just an example, Kaplan-Meier survival curves for the endpoint HCM-related death, where you can see that there are no differences for what concern a patient with different protein mutated. So to conclude, I would like to attempt to give some messages, both from the genetic point of view and clinical, so that for what concerns molecular genetic in end stage, we can say that these patients have the same spectrum of genes and mutation of patients with classic HCM, that they have a relatively higher genetic burden. However, current genetic data are not sufficient to explain this phenotype. And to give some clinical implication or genophenotypic correlation in the largest series of end-stage patients, we can say that we found a relatively younger age in patients with multiple mutation, a slight female preponderance, a late occurrence in patients with myosin-binding protein C, and that the outcome was not related to genotype. Thank you for your attention.
Basically, did this surprise you? That molecular findings don't predict
Yes.
the end stage. And The corollary of that is, what does?
Yes, I agree. Actually, we were a little bit disappointed since we were expecting that genetic background could explain more to us for this development of this terrible disease. So we can say that probably we don't know enough about genetics, so that, of course, we can say that environmental factors, modifier genes, whatever, variants, and so on, that we don't know yet could explain this, and that maybe, as we learned this morning, next sequencing generation will tell us. We don't know, even because interpreting this data, of course, it will be so difficult. But we indeed, we are a little bit disappointed, because anyway, there is an important familiar aggregation that, for me, seems to say that there is something, even in the genetic background, that we didn't find. No, at least not enough, because there is more multiple mutation, but it does not explain everything.
Right. Yeah, it's disappointing, but it was predictable, because, single mutation analysis has not predicted the future in hypertrophic cardiomyopathy for anything, including sudden death. Any other questions?
Very nice talk. I wanted to ask if you found a difference, you may have mentioned it already, in the amount of myocardial scar or wall thickness in your genotype positive versus negative group.
For what concerns scar, you mean fibrosis?
Yeah, fibrosis.
We perform MRI just in 36 patients. Since we perform blood tests in the last few years, but these patients were followed in our group since many years. So many were already transplanted or had an ICD, so it was not possible. So we have 36 MRI, but we did not analyze these
That
studies.
might be something interesting to see what the double mutations do to the phenotype.